This is one surgery which every ophthalmologist should do and can do, and this is the phakic PCIOL, which is the future of refractive eye surgery. Now, this is an individual who had a significant myopia in right eye, and this is the fundus photograph. We can see some myopic changes, and this is the refractive status showing minus 13 diopters of refractive error. Placing an incision at 90° superior 12 o'clock site. The purpose is that there should be minimally induced astigmatism, as there is no preoperative astigmatism. And one thing to be noticed is that these individuals are young individuals, and this person is 25 years of age. So they are more sensitive, more apprehensive, and the guards are higher. So they have higher possibility of Bell's eye phenomena and stronger blepharospasm at imminent threat. So, but if you continue surgery and keep them reassuring, they cooperate well. Putting in intracameral lignocaine, and notice the pupillary dilatation which will improve with this intracameral injection. I always use this, and it makes the manipulation much tolerable for the patient and the surgery much more painless for the patient. Now, for phakic IOLs, it is extraordinarily simple, and anyone who has done phaco surgery with clear corneal incision will instantly realize that the steps needed for removal of the crystalline lens are missing, and the moment you enter the anterior chamber and put in viscoelastic, you are ready to implant the phakic IOL. Turning off the retroillumination, and this is how we go for implanting this phakic IOL. Now this is refractive intraocular lens as named by Appasamy Associates, and the aim is that the leading haptics should go into the sulcus directly, so that reduces the need for manipulations. If the pupillary dilation is good and the injector tip is proceeded up to the midway of the cornea, it is possible to inject the leading haptic directly into the sulcus, which is the resting place for this IOL. Once you have placed the IOL in the chamber, always replenish and inflate the anterior chamber, and then see if you need to dial the trailing haptics as well. Here we have one of the haptics which is still in the anterior chamber, and this can be very easily dialed into the place behind the iris. Now, for anyone who has done PCIOLs, he will instantly realize that these IOLs are very large and very bulky, and that makes this surgery a little intimidating for an average cataract surgeon, because usually the posterior chamber IOLs are not as oversized compared to this, but there's usually just an apprehension, and anybody who has ever implanted a PCIOL, I believe he can do this surgery. Positioning the IOL, and here we can also see that there is a central hole which excludes the need for any peripheral iridectomy. Putting in injection pilocarpine, I usually dilute my injection pilocarpine by half dilution by mixing 1 ml of pilocarpine and 1 ml of BSS, and this makes the injection and subsequent ciliary body spasm less painful and tolerable for the patient. I always use intracameral pilocarpine because it assures me that the haptics are lodged properly in the place, and there is no possibility of leaving behind any haptic in the anterior chamber. proceeding for washing away the pilocarpine and viscoelastic, and this is one of the most important steps because it is usually seen that these patients will develop a very high IOP and secondary glaucoma if viscoelastic is not properly washed. And as compared to a cataract surgery, there is a tendency for leaving behind the viscoelastic because the surgeon is very much apprehensive about touching the crystalline lens which is already there behind the phakic IOL, and that is why the viscoelastic removal is less aggressive and less time is given to that process. So give enough time to wash away the viscoelastic. It's very important, and don't allow the chamber to get shallow. Here we are placing a bud just before withdrawing the irrigation aspiration cannula. Putting in BSS to inflate the anterior chamber. If needed, one can also hydrate the wound, but usually if the tunnel is adequate length, it will usually contain the IOP. Now proceeding to the other eye, these surgeries are usually done in pairs unlike cataract surgery, and this is the other eye with lesser refractive error. This is -5 diopters of refractive error, which could have been a candidate for a LASIK surgery, but here we are doing phakic IOL for both the eyes. Placing the incision at 12 o'clock position, clear corneal incision, and you can see the pupillary dilation is not as ideal, but we'll just witness the moment the intracameral lignocaine is injected, the pupil will dilate. Here I have turned off the retroillumination so as to expose the retina less to the ongoing illumination. Now retroillumination or the glow is not very important for these patients because we are not intending to see the lens fibers or have to remove the cortical matter. We can see the pupil has dilated well now. Proceeding for viscoelastic 2% methylcellulose injection, and we can see the pupillary dilation is excellent now, and directly going for implantation of the phakic IOL. I'll just repeat that this is refractive intraocular lens by Appasamy Associates, and this has a central hole, and they are provided also in toric variety if there is significant astigmatism. You just witness that the leading haptics have gone into the sulcus without any need for manipulation. The trailing haptics are in the anterior chamber, and this will be dialed into place, confirming that the leading haptics are in proper place. Managing the trailing haptics have gone into the place. Some amount of dialing motion will usually help in placing these IOLs in position. It's very reassuring if your IOL is well centered. Once we have the IOL in place, then again proceeding for intracameral pilocarpine just to constrict the pupil. And this is, again I will repeat that this is diluted pilocarpine, diluted to 50%. There's a central hole which we can see just now, and this makes it needless to do a peripheral iridectomy, either surgical or laser assisted. Washing out the viscoelastic material. And my only comment here would be that Every ophthalmologist who is doing cataract surgery can do this surgery and should take up these cases so as to learn this technique. And I know that in numerous discussions I have had opinions from my colleagues who say that this is going to be the future of refractive surgery, owing to so many advantages it offers when compared to corneal refractive surgeries. And there is no initial bulky investment needed for this surgery because all that you need is already there if you are doing cataract surgery. Unlike corneal refractive surgery, which requires a huge amount of investment in form of excimer laser or femtosecond laser. And the results are instantaneous, and there is no haze, there is no regression, and the reversibility is excellent. The cornea retains its natural shape, which is so very important for good vision. And these are all the advantages except the one that this becomes an intraocular procedure. Thank you.